All right, thank you. Thank you, Charlie. Appreciate it. Thanks for coming. It's a real honor to be here, not just with our esteemed panel, but also with a lot of you. And many of you are probably thinking a lot about tomorrow's race as well. So I appreciate you spending some time with us. So we'll be talking about the Masters runner for the next bit, and it's a group that I treat a lot, and I'm also a member of this demographic as well. So I have no product endorsements. If you want to follow us on social media, those are some good places. I think Instagram is probably the best place. But the outline for today's talk will be, we're going to talk about how as we get older, our injury risk and injury profiles change quite a bit. We're talking about why that might be, and a lot has to do with the changes in how we run. So our biomechanics change as we age. We also get a change in our tissue mechanics, which is kind of the underlying driving factor for almost all this stuff that we'll be talking about. And of course, we'll be talking about strategies to combat age-related changes, both in injury, but also in our biomechanics and perhaps even our performance. So first, I think it's really worth operationally defining what exactly the Masters runner, who the Masters runner is. And it depends on what organization you're looking at. And USA Track and Field defines the Masters runner, I believe this is also how the London Marathon defines it as well, as an individual who is 40 years of age or older. World Masters Athletics is a little bit younger. And it is indeed the fastest growing segment of marathoners in the world. And so since 2016, it represents over 50% of all marathoners. And we see a very similar pattern when it comes to ultra marathoning as well. So if you're a clinician and that's a population that you work with, you probably have noticed that as well, that a lot of ultra marathoners tend to be older. So I think you can apply a lot of the material we're going to be talking about for the next half an hour to that group as well. Now, just because you're getting older doesn't necessarily mean that you're getting a lot slower. So this is Mariko Ugeta, and she holds the world record for over 60 for the half marathon of 1 hour and 24 and 42 seconds, which is unreal. And then also for the marathon of a 2:56, those are just incredibly fast times. So so besides being an age category and I don't know, maybe thinking about Radiohead and Kid A as being still a cool, fresh album, how else can we tell that we're becoming a Masters runner, or a growing affinity, as I have lately, for Paul Rudd comedies? Well, one of those is that we all start slowing down as we get a little bit older. So this is Ed Whitlock on the far right. He's since passed away, but he was the world marathon record holder for, I think he set this when he was 74, I think, which is just an unreal time of 2 hours and 54 minutes. But what we see is that, of course, on our graph here, we have males and females. And this is the mean running pace in minutes per kilometer. We see a very gradual decline in our running pace as we get older. First, between the ages of 30 and 50, it's pretty small. And most of the thought right now is that the reason why we start slowing down during this time period is not so much because of biomechanical factors, but more because of life factors, okay? Basically life starts happening. We can't train as much. We start having children, or jobs take a greater importance in our lives. But once we get past the age of 60, this is when things really start accelerating. And so this is when we really start seeing that age-related decline in running pace. So it seems to be kind of slow and kind of gradual at first, with an ever-accelerating pace after that. So I think then, I think it's a really important question to take a step back and say, well, why is it exactly that we slow down with age? So this is Joan Benoit Samuelson. So I don't know, for me growing up in my household, my mother was a big running fan, and this is getting to watch her in the 1984 Olympics win the first women's marathon gold medal. She won it in with a 2:24:52. Age 52, she still is running quite quickly. I think she's in her early 60s now, and I think she's just over 3 hours at this stage. So why is it that even elites tend to slow down? Well, there are a lot of reasons for that, but a big one is injuries. We all start getting injured not just more frequently, but we're also dealing with more injuries at the same time. And so I think Izzy mentioned it earlier, but the number one predictive factor that you're going to have an injury is if you've had that injury in the past. And the older you are, well, frankly, the bigger history of past injuries you have. And so the likelihood that you're going to experience one of those injuries again in the future goes up. And because you've had more injuries, you're going to be more likely to experience more and more injuries at the same time. So not just that we're getting injured more frequently, but also more at the same time, but also the type of injuries that you will experience also changes as well. So this is Bill Rogers, nicknamed Boston Billy because he won the Boston Marathon 4 times. He's from Boston. And he also won the New York City Marathon 4 times as well. So he's a neat guy. If you've ever had a chance to listen to him speak or spoken with him yourself, he's kind of like a surfer type guy. He's really neat. But I think I want to say he's probably 70 at this stage. But he still is very active in masters running. So when we're young, we tend to get much more knee-type injuries, so patellofemoral pain, iliotibial band pain, and those are the preference or the prevalence rates below each one of these anatomical areas. And when you look at this, about 25% of all running-related injuries is patellofemoral pain, followed very closely by iliotibial band pain. So if you're going to be working with runners, particularly adolescent and 20-year-old runners, you should be very, very good at treating relative overuse injuries of the knee. Bony stress injuries, as we heard earlier, those are incredibly common in this population as well. So if you're working with the adolescent or high school runner, bone stress injuries, I think a lot of people will lump medial tibial stress syndrome in this group as well. And so we're basically seeing these kind of knee-type injuries and bony-type injuries. But once we get to be a little bit older, that profile changes considerably. So then we start seeing plantar flexor strains. We start seeing Achilles tendinopathy, and that's going to be probably the most common running-related injury that we see in the masters runner. Plantar fasciopathy or plantar heel pain, we used to call it plantar fasciitis. It's also quite common as well. And the other injury, unfortunately, there's not a prevalence statistic here, but gluteal tendinopathy, and it's also known as greater trochanteric pain syndrome. It used to formerly be considered to be hip bursitis, but this is really this is a tendinopathy of the gluteus medius and the gluteus minimus tendon. So when we look at these, you can see we get this big shift from more bony and joint type things to everything is going to be soft tissue related. And those things, I think that's a really important thing for us to think about as we move forward for the rest of this talk. The one thing you don't see on there is a greater risk of knee osteoarthritis. So this is a dose-response relationship, this very kind of classic U-shaped curve. You see this with water consumption, like tomorrow. If you don't drink enough water, you're going to have some problems. If you drink too much water, you're also going to have problems. So there seems to be a bit of a sweet spot from a physiological, like from a homeostasis standpoint, for a lot of interventions, and running I would consider to be one of those. So this is on the y-axis, we've got knee and hip osteoarthritis prevalence, and then along the x-axis, we have running volume. That's going to be lifetime running volume. And what we see is if you're sedentary, meaning you're a non-runner, about 10% of all individuals will have or experience hip or knee osteoarthritis. For the recreational runner, we see that this rate will drop considerably, down to about 3.5%. So recreational running seems to be actually chondroprotective, meaning that it seems to reduce our risk of developing osteoarthritis of the hip and knee. I think this is a really important message for us to get out if we're a clinician to our patients and to the general public that, look, running is actually quite healthy for your knees, it's quite healthy for your hip, and it's something that you should consider continuing to do, even if you're experiencing some joint-related pain. And I think it's important to work with a healthcare practitioner to understand how you can maybe perhaps modify your training so you can keep training. But what we do see is with the elite runner, we see a greater incidence or greater prevalence of hip and knee osteoarthritis in this group. And so the elite runner, by the way, is defined as a professional or someone representing their country. So these people have a relatively high rate of hip and knee osteoarthritis. So it seems to be a bit of a sweet spot there. For people who are running at a very, very high level, those individuals do tend to experience more hip and knee osteoarthritis, but I think most of us don't fall into that category. So I think a really important message for us to get out from a public health standpoint. So one of the things that happens as we get older is that we start experiencing sarcopenia. And sarcopenia is the age-related loss of muscle strength, muscle quantity, and also muscle quality. And the reason why we're talking about quality here is because what we start to see is fatty infiltration into the muscle, and I'll show that on the next slide. We also start to see a declining physical performance. So things like it takes longer for us to get up out of a chair or walk a certain distance. And when we look across the entire body, sarcopenia doesn't affect our body equally from a muscular standpoint. So in fact, lower extremity muscles are affected at about double the rate of upper extremity muscles. And the reason for that is that we have more muscle mass to lose in our lower extremity. So this is really nice MRI of the gastrocnemius in an older individual versus a younger individual. So I think most have seen these pictures. They seem to have been making their rounds pretty regularly for the last decade on social media. But on the far left, we have a 40-year-old triathlete. And on the far right, we have a 70-year-old triathlete. And you can see that there really isn't a lot of difference between these two individuals. In the middle, we have a sedentary 74-year-old individual. And there you kind of see that marbling of their hip, and their hamstring and quadricep musculature. And that's that fatty infiltration that you're starting to see that's working its way into the muscle. So these are muscles that don't contract as forcefully or contract as quickly. And so the highly trained masters athletes, they mostly preserve these critical muscle qualities, as you see on the far right. But what seems to be the case, though, is that consistent endurance training alone is not sufficient to maintain muscle mass and muscle function. And that's where we are with the rest of this talk. So the big thing that changes is that we start to lose plantar flexor strength as we get older. And it doesn't seem to matter if you're a runner or a non-runner, we do start to lose that. And so we're about 10% lower plantar flexor strength when you look at the average 65-year-old versus the young individual. We start to lose cross-sectional area of the plantar flexors as well. The reason why that's really important is because, of course, attached to these plantar flexors, meaning the gastrocnemius and the soleus musculature, is your Achilles tendon. And because the muscle is not going to be pulling on the tendon as forcefully, the tendon starts to kind of adapt by becoming less stiff. And while that might sound like that's a good idea, actually we really need very stiff tendons because when we running is basically a plyometric or a hopping type activity. And so we store and release a lot of energy in our tendons. And if you have a loose tendon versus a stiff tendon, a loose tendon is not going to store as much energy. So one of the things that's really important is that there's a relatively strong correlation between plantar flexor strength and Achilles tendon stiffness. So the stiffer one's Achilles tendon is, the likelihood that they're going to have a stronger plantar flexor is really quite good. And so the flip side of that would be as you lose strength in your plantar flexors, your Achilles tendon is going to lose stiffness. So really important. And the reason why that's so important is because, as I mentioned earlier, we basically are this pogo stick when we're running. And that spring that you see, this is the mass spring model. From a biomechanical standpoint, this is how we model running. And the mass spring model, the spring, of course, are all of our tendons. And so the tighter that spring is, the more efficient we are going to be at running. And it relates very closely to running economy, which is the metabolic cost of transport at submaximal running speeds. So when we compare leg stiffness in the older individual versus young runners, what we see is that masters runners do indeed exhibit lower leg stiffness. But one of the things that's really important, this relates back to why we start to get slower as we get older, is that the faster you run, the less leg stiffness you have. So you're getting less energy storage and release from your plantar flexor tendons, and as a result, you start getting more and more load on your plantar flexors, which is one of the reasons why we start to experience more plantar flexor strains as we age. So plantar flexors take the biggest hit, it seems. And so when we're talking about loss of tendon stiffness, we're talking about loss of cross-sectional area, it seems that the lower extremity seems to be affected much more than the upper extremity, and of the lower extremity muscles, the plantar flexors seem to be affected the most. And so the reason why this is important is because, as we start to age, the more tendon strain we experience, we have a greater potential for accumulating micro damage of our Achilles tendon. So here's our young plantar flexor unit contracting. And here is the masters runner plantar flexor unit contracting. So you can see that we're starting to experience a greater length or strain, and that's thought to contribute to the accumulation of micro damage in the tendon. So we see 31% less plantar flexor power during running as well, and that has to do with the fact that we don't have as much muscle to push off with, and there's some serious consequences for this. The big one is we're going to have a greater risk of Achilles tendinopathy, and we're going to start to lose step length as we age. So we start to kind of have this more of a shuffling type gait pattern as we get older. We lose about 4 centimeters of step length per decade. So, and this is one of the reasons why when you look at someone, maybe perhaps tomorrow, if you're spectating, you'll see some of the older runners go by, you'll see them, they'll have kind of much more of a shuffling type gait pattern than this very bouncy pattern that we saw with Kipchoge earlier, which was really impressive to watch. So when we, going back to why the plantar flexors are so important is because when we look at the muscular contributions to running, what we see is that running is actually not very much of a glute-dominant activity as much as Runner's World or Triathlete Magazine might tell us. You can see that this is going to be in body weights of muscle forces. You can see that the glute max actually plays a very small role in our forward propulsion as we run. Where we do see a massive contribution is from our plantar flexors. So running is primarily a plantar flexor-driven activity. And of the plantar flexors, we see the greatest contribution from the soleus muscle. So the soleus is kind of really where it's at when it comes to age-related changes in both injury risk, but also age-related changes in running performance and running biomechanics. And when you look at the cross-sectional area and the muscle volume of our plantar flexors, you can see that the soleus represents 64% of the total volume of our plantar flexors, and the medial gastroc and lateral gastroc just 37%. So it's a really important muscle. We often don't think about it because you can't really see it that well. It's covered up by our gastrocnemius musculature. So we should really pay a lot more attention to the soleus, both in our rehab and also our injury prevention strategies that we're doing. So our Achilles tendon is really neat. It's actually not a single tendon. It's actually a series of subtendons, and as they come down, it's like a braided rope that does a little bit of a twist. And when you look at the cross-sectional area of that, you can see that even at our Achilles tendon, the soleus makes up the largest proportion of your Achilles tendon. And the reason why this is really important is because if you have Achilles tendinopathy you always will see a strength deficit or strength loss, and the soleus portion represents almost 3/4 of our total strength loss with our plantar flexors in individuals who have Achilles tendinopathy. So when we're doing our rehab for people who have Achilles tendinopathy, we really need to be paying a lot more attention to trying to some very focused loading of our soleus so we can improve the health of the soleus subtendon. So when we're talking about how can we reduce some of the age-related loss in performance, some of the things that seems to be coming out in the literature is that periodic high-intensity training, so continuing to go to Tuesday track workouts, maybe doing hill repeats, and also keeping your running volume quite high, seems to slow the age-related loss in VO2 max, leg stiffness, as we've already mentioned, and we also seem to preserve some of the propulsive forces and ankle power as well. But one of the things we don't really know, this is all like kind of cross-sectional data and looking at case controls. What we don't know is if these things have already happened for you, if you start adding these things back in, can we restore this function and restore our speed? So I think we probably need some intervention studies yet, but definitely something to be thinking about. And as you're getting older, you should definitely make sure you're still hitting Tuesday night track workouts. So there's some different types of run training that emphasizes the plantar flexors. One would be if you just do a small uphill, 5% uphill. This is actually a picture of Missoula, Montana, in case anybody is interested in what it looks like. But the trail running is really amazing there. And we have, this is actually quite close to our house. You see that when you run uphill, you have about 12% greater ankle power as you run uphill. So this is a great way to be stressing your plantar flexors a little bit more. Doing strider work, so striders and speed work, we see just a very small increase in our run speed. We see a much larger contributions from our ankle plantar flexors. And then the one that was a little bit surprising for us, we've done some comparisons between overground and treadmill running. And just running on a treadmill at the same speed, you have about a 28% greater ankle power contribution. And so maybe perhaps running on a treadmill once a week, maybe even doing some speed work on there is a great way to still emphasize or stress your plantar flexors. But there's, load is not good or bad, and so you have to be a little bit careful too, because if you do too much of this work, particularly if you decide after the marathon or after this talk, you're like, I'm gonna go start doing intervals on the treadmill with a 5% incline, that might be a really rapid change in overall training load for you, and it might increase your risk of developing an Achilles tendinopathy or some sort of plantar fascia issue. So tendon thrives under very, very high load. So we're really getting into some strategies on how we can combat these age-related changes in muscle and tissue qualities. Doing 12 weeks of heavy strength training. So 70% of your maximal voluntary contraction. What that means is around 12 to 13 reps is the max that you can do with when you're lifting a weight. You should be at least there, if not higher. That seems to really increase tendon stiffness. We see minimal changes in Achilles tendon stiffness with just continued running. So if you're thinking, well, I'm just going to keep running and I'll be fine, that doesn't seem to really have any sort of effect on your Achilles tendon stiffness. So you need to be doing some sort of supplemental training. And we know that if you want to try to optimize the tendon response, you need to be loading long and slow. So 3-second repetitions on the way up and 3-second repetitions on the way down on your eccentric phase. So long and slow. Bone is a little bit opposite of that. Bone you want to load a little bit quicker, and that's why hopping and plyometric type activities give you a much better response out of bone. The second part is that tendon gets bored very quickly. All right, so this is going to be the tendon mechanosensitivity. In other words, this is how quickly or how responsive the actual tendon is going to be to doing repetition. So if you're doing 3 sets of 8 for like heel raises, you're going to be within your 0 to 20 total repetitions. So it's going to respond really quite well to that. But what happens is as you add a number of repetitions through more and more sets, what we start to see is that tendon mechanosensitivity, or the ability for that tendon to respond, is going to decline quite a bit, to the point where once you start getting to 50, 60, 100 repetitions, that tendon is not going to respond to that, and it's not going to get stronger. You may gain bulk in your plantar flexors, but you're not going to gain stiffness. So this is a really important slide coupled with the last one. You really want to be lifting heavy, and you really don't want to be doing a lot of repetitions, because the more repetitions that you're doing, the greater likelihood you might start accumulating some micro damage in the gym and might actually increase your risk of developing an injury. This is a really cool study where they looked at heavy versus moderate resistance training. So these are in older individuals, and I believe the mean age was 65. So 3 sets of 6 to 10 repetitions is at 70 to 85% of 1 repetition max, which is just what we were talking about is our optimal range, versus 3 times 18 repetitions. And when you think about the average runner is really going to be thinking, I'm running, so I need to be doing strength training for endurance, and so they're probably going to be doing more of the 3 times 18 repetitions. And when you look at this, both groups gained strength, and they were doing knee extensions for a year, actually, so they were doing this 3 times per week. We had 20% improvement in quad strength in the heavy group, and moderate group, not quite as much. But this is the important figure, and that's that the heavy group saw an increase in patellar tendon stiffness of 8%, whereas the moderate group continued to lose tendon stiffness. And actually, that was not different than the control group that didn't do anything except continue to get older throughout this for the next year. So doing heavy strength training is really the way to go when it comes to preserving and actually improving tendon stiffness. So some basic principles for resistance training for tendon health. We know that we want to be lifting heavy and slow. All right, so 6 to 8 repetitions, maybe not start off here. You want to get to this point eventually. 3-second phases, so 3 seconds on the way up, 3 seconds on the way down. Make your reps count. So a lot of volume is not needed. You should be doing your strength training before you go out on a run. And the reason for that is that if you do your strength training after a run, you've already lost that mechanosensitivity of the tendon. And so do your strength training before you go for a run if you need to be stacking your workouts. And if you're worried about having like a training hangover, for your feeling after you've done your strength training that maybe the next day you feel a little flat, the thing to do is reduce your overall volume, so drop a set, whereas I think most of us have a tendency to maybe drop the overall resistance level, and I would encourage you to keep that resistance quite high, because otherwise you're not going to be getting that beneficial effect of your resistance training sessions. So capacity training, we're going to talk about how you can target the plantar flexors a little bit more ideally. And so the way you want to do that is get into something that's very stable. So a Smith machine is a great place to be doing these types of exercises. You don't have to worry about getting very high up on your toes, because we can lift the most amount of weight between 20 and 30 degrees of dorsiflexion up to neutral. And again, 4, 6, 8 repetitions of that, 3 to 4 sets, and certainly not more than that. To target the soleus, you need to flex your knee at least 60 degrees, and so doing it on a soleus machine is really the way to go. And of course, with this, you're looking at more of around 90 to 100 degrees, and this is going to really take the gastrocnemius out of it and put the majority of load on the soleus musculature, and of course, you're going to be loading in that soleus subtendon. If you don't have access to that, you can do it on a knee extension machine. So I'm just sitting on a chair. I put that knee extension machine arm up on my thigh, and you can do your seated calf raises in this manner too. And so if you have a clinic that doesn't have a soleus machine, this is, and hopefully you have a knee extension machine, which I think is a critical piece of equipment if you're rehabbing people with lower extremity injuries, that's the way to go. So this is considered to be best practice for plantar flexor strains, fasciopathy, and Achilles tendinopathy. So a little bit of a heads up, I'm going to show a cadaver foot on the next slide. So, all right, so plantar fascia. This is a wonderful, wonderful dissection of the plantar fascia. And you can see how it originates off that medial calcaneal tubercle, and it goes up to each one of your digits. When that is loaded is when we go into great toe, or when we go into toe extension, and that's when you're going to get the most load on your plantar fascia. So when you're doing dorsiflexion exercises, when you're doing those heel drops, the plantar fascia, as you can see there, is actually going to be on slack. So you're not going to really load your plantar fascia a whole lot. Where you do load it is when you do go up on your toes. So you can see we've engaged that windlass mechanism. We're starting to get a lot of load on the plantar fascia. And you can see that we're actually really getting after it because we're putting a towel roll up under the toes to really emphasize that that toe extension is going to really focus a lot of load on your plantar fascia. The way to do this is to start off with some dorsiflexion exercises and then eventually progress onto that with your rehab. So the other thing, and we'll kind of be wrapping up here, but we need to make sure that with our athletes, we're planning for a rate, for a slower rate of adaptability. So after you finish the marathon, one of the things when you look at older runners versus younger runners is that older runners tend not to regain their tendon stiffness as quickly. So young runners, meaning like in their 20s, they tend to regain tendon stiffness within an hour or so of doing a long, hard effort. So it'd be speed work or what have you, or a long run or a marathon. Older individuals, they tend to take 24 to 36 hours to regain that tendon stiffness. The reason why it's really important is because you want to program in more rest into your training programs or your rehab programs for your older athletes. So rather than maybe doing a hard workout every other day, maybe perhaps doing a hard workout every third day. And adolescent tendons are quite a bit more adaptable, and older, we just don't respond as quickly, so that's something else you need to consider too when you're working with the older athlete. And then the final thing here too is make sure that you're paying very close attention to pharmacology of the athlete. We know that some of these broad spectrum antibiotics, so Cipro, Levaquin, these drugs have a major effect on collagen synthesis, not just when they're taking that drug, because typically people are only going to take them for a week to maybe 10 days at the most, but we see a very long effect on our tendon's ability to synthesize new collagen. And so you need to be asking your patients, hey, tell me about the drugs that you've taken in the last year. Because if that's the case, you need to work on slowing down your progression with your patient's exercises. And same thing with statin use, which is going to be much more of a chronically used drug. So some take-home points. Running is quite good, okay? So it's part of successful aging, but it's not quite enough. And so to do that, we need to be doing some strength training 2, maybe 3 times per week for the athlete who is responding really quite well. Go heavy, but with very low volume. Target the plantar fascia and the plantarflexors, and do that with weighted heel raises and heel raises up on your toes. And finally, plan for more recovery time. Give yourself some time to adapt to these training loads. You're not 25 anymore, and as much as you might think that, I don't know, Kid A is a wonderful album still, your tendons have aged along the way. So some quick acknowledgements, and thank you very much. I'll be happy to take any questions.
Thank you so much. That was absolutely outstanding. Does anybody have any questions for Rich? Yes, one in the middle over there.
Hi, thanks for that. I was wondering how your research and what you shared with us today applies to masters runners who actually start running later in life. So I was thinking of, for example, Sinead Dever, the elite Australian marathon runner who's 45 now, but actually started running when she was 36. So obviously at a different stage of her journey compared to your typical masters runner.
Yeah, so I think you're looking at, there's lifetime age and then there's runner age, right? And so that they've only been a runner for 10 years. So they haven't had a chance to accumulate a lot of past injuries. So that person is probably not going to be experiencing as many injuries as someone who's been running for 20 or 25 years. I think that group is pretty interesting. Ed Whitlock, the gentleman I showed earlier, who I believe he still holds the world record for the 70 to 74-year-old age group for marathon. He was also like that too. And so he started running very late in life. I think started running in his mid-40s, so very similar. And that person is probably going to be running much better or running for much longer into their life than someone who maybe has been running since they were a teen. My guess is, and I don't know anything about her, but my guess is that person probably played some sort of running sport when they were in high school, so they could build healthy tendons and healthy bones. And I think that's the other thing, that's the other group I worry about a little bit too, is the runner who specialized in running as an adolescent, who didn't do other sports. I think that person is going to have some more issues as they get older with experiencing relative overuse injuries versus someone who did a lot of sampling, who maybe has a tendon and bone, or tendons and bones who haven't experienced so many micro injuries along the way. So yeah, good question.
We'll do one more question at the back over there, and then we'll hold the rest until the round table.
Thank you. My question is about the change in timings with the marathon coming up in April next year again. How that might affect injury rates, and are the masters athletes at a greater risk or not at all?
Yeah, that's a great question. I think after any big event, you want to take a little bit of downtime. But I think where we see more problems, and we have some really big races in Missoula that are like some ultra marathon events, for instance, and people will get done with that race and then they'll take a big block of time off, like maybe a month off, where they're maybe just doing some hiking or something like that. But then they try to ramp up very, very quickly for maybe like a November race. And I think that when you do that, you have to be very careful because you have a period of deloading, and then you want to ramp up very, very quickly because you've got this marathon in just a few more months. So I think what I would probably recommend for the average masters runner is to take a little bit of downtime, give yourself some time to recover. But I would try to get back into some regular training within 2 weeks and not take too much time off, so you're not losing too much capacity. So that once you start doing that marathon-specific training, you're not going to get a marathon running-related injury because you're trying to ramp up in a much shorter period of time than if you were to have a longer runway, basically, between year-to-year race. So yeah, it's a great question.
Perfect. Thank you very much, Rich.
All right, thank you.